Hello, my name is Dr Paul Macnamara. I'm an orthopedic consultant specialising in hip and knee replacement. The meniscus is basically the body's shock absorber within the knee joint. It's the blue part between the femur, the thigh bone, and the tibia, the shin bone. Pain is the main symptom. With that comes what we call mechanical symptoms, which we may describe as a pseudo-locking, where the knee is just catching and you have to kind of unlock it straight, and also giving way. It may feel a little bit unstable. We can ascertain whether this is an acute injury based on the injury that you had maybe playing football a few days before, or whether this is long-standing after maybe what we call a degenerate tear. And these usually happen in the kind of middle ages. It will be painful, and as I said, there will be mechanical symptoms that may be catching and locking and giving way. It just won't feel right. And compare it to the normal knee on the other side, it will feel very different. For young, fit individuals who have a lot of activity, then definitely you need surgery with an acute injury. There is no evidence now to suggest for what we call degenerate tears, i.e. the middle-aged tears, that we need any surgery for that. Now that is lots of randomized controlled trials, which is a lot of science basically saying that there's no great evidence for just washing out the knee and trimming a meniscus. 25% of 40-year-olds have a meniscal tear as an incidental finding on an MRI scan. This is very different to the way we were treating these maybe 15, 20 years ago, where we were going in and trimming all the meniscus. Now we don't consider that to be an option, and in fact the results have borne that out through lots of multi-center trials throughout the world. If it's a degenerate tear and you can build up the muscles, if it's an acute tear, i.e. one done maybe playing football, it's very unlikely, and those are the ones I would like to assess and maybe consider at some point operative intervention. There is no real blood supply in a lot of the meniscus, and as a result it doesn't heal either. There is some healing potential near the back and the sides of the knee, and we may be able to use that to save some of the meniscus if we're going in operatively to stitch it back. But we have to make that assessment based on the scans and also what we find in theatre. Well, ideally you want to save as much as you can, so the best treatment would be a meniscal repair, but that would, as I said, depend on the location, the size of the tear, and also the age of the patient has a factor on it, and whether they have any other pre-existing comorbidities, because really the success for those are much less. Now that is arguable when you go with a bunch of surgeons, but there's no doubt that the results are slightly worse than if you just remove or trim a little piece away. So I usually offer people a 75% chance of success with a meniscal repair, where I've stitched it together, as opposed to a meniscectomy, which is over 95 to 98% success. A meniscectomy is just a fancy way for saying we will just remove a little piece of it. If I give you an example, this is a meniscus. Normally, this has what we call a stable rim, but in this model, they've actually reenacted a tear. So you can see the thing is flapping around. You can see that when you move the knee backwards and forwards, this is going to cause pain. And so the best thing to do in this situation, given the location of the tear, is just to remove that little aggravating piece away. And we do that with a series of shavers and some little heat wands. The incisions are very small, so really just to take a camera, it's no bigger than about a centimetre. One is a camera and one is a shaver on the other side. So you're not talking about a big incision that I would do for, say, a hip or knee replacement. And that's why patients can go home the same day. This has some pain, but I'm not giving big, heavy opioid painkillers, so I don't usually need to give anything very strong. I usually give a bit of an anti-inflammatory and maybe a little paracetamol afterwards for a few days, depending on how much work I've done within the knee and depending on the individual themselves. I've certainly had patients that I've done on a Monday and they've almost been bouncing back by the following Saturday, but some other patients may need a full 6 weeks of recovery, and it just depends on the type of patient and also the amount of work I've done within the knee. Usually if it's a population that have been quite sporty that have this, then I would definitely advise just taking it easy for a bit. It is quite common to feel like, well, I've got no symptoms now, I better go back, I can go back to playing football after a week or two. I wouldn't advise that. I'd probably wait about 4 or 5 weeks for that.